Okay, and we should be good. Lisa, go ahead.
All right, welcome. Our speaker today is Heath Davis, MS, MLIS, FAMIA, and they're the Assistant Director for the Biomedical Informatics Core of the University of Iowa Institute for Clinical and Translational Science, as well as the Assistant Director for the Iowa Health Data Resource, or IHDR, where they lead the Intercollegiate Advisory and Implementation, or IAI team. And librarians, you should be well accustomed to acronyms. They architect new data sets and led the creation of a secure data enclave for processing PHI data using high-performance computing and interactive data analytics services, and facilitates the EPIC optimization for research initiative with the University of Iowa research community. So that is a lot of laurels. And looking forward to hearing the talk today. Thank you.
Super. Thank you for the welcome. I appreciate the opportunity to talk to you all today about Iowa Health Data Resource. Let me share my screen here. All right. Are you able to see that now?
Yep.
All right. Super. So this is a project that my director and I have been working on for about the last 18 months. Boyd Nosp is the director for this project. He's also Associate Dean for Information Technology at University of Iowa, and he is also the Associate Director for Biomedical Informatics. So we work quite closely. What we do in our world, how do I navigate? There we go, other way. First, what I'm going to talk about, I'm going to give you a little bit of background, what led to the Iowa Health Data Resource, some of the outcomes that we've seen in the last 18 months and our goals, and then resources that are available. The data resource is a really great resource that we're proud of. It fits into our environment, but part of the goal of the resource is to expand knowledge about it and have more research teams use it. So background, I'm part of ICTS, which is a Clinical and Translational Science Award program here at University of Iowa. It is more than 50 research institutions. It's part of a program through NCATS. At Iowa, this program is led by Dr. Winokur and Dr. Hansen. Boyd and I lead the informatics core for the Clinical and Translational Science Award here. What our team does primarily, we do a lot of things around informatics consulting and data. We run a number of tools for research. I work with HCS and their team around EPIC. We do other technology consulting. But what we're really focusing on today is the Health Data Resource, which has to do with a service that we run called the Clinical Research Data Request Service. And that's where we act as a broker for data for the institution for research when it comes to data out of our medical record. So everything is in the context of that. Most informatics groups, most CTSAs, most academic health centers have a concept of an enterprise data warehouse for research or a clinical data warehouse for research, and that's different than the operational warehouse. And it does several different things, but we have data sources. We transform those data sources, we normalize them, we filter them, we may map them against taxonomies and ontologies. We may put them in different repositories, databases and data marts, so we curate that. We manage different collections for domains. And then we have ways that our users can access these data resources or these information sets through self-service tools and queries. And then we use these for a number of different research purposes. So most academic health centers have some version of this. And my boss's research is primarily focused on maturity models. And maturity models are a way for an organization to assess where we are with a process, how mature, how established a process is. And he's been researching different things in academic academic medicine for a while, but he started looking at these enterprise data warehouses for research in about 2018 and deploying a maturity model to assess that across different CTSA organizations. So his first paper was published in 2018. He's been working with the informatics community. There are a number of different communities related to CTSAs and academic medicine. And then he published, he has a most recent maturity model paper coming out just this year. So there's some background to this. So he went out, he explored this with some of his peers, and then he brought those learnings back to our community. So in their first pass, they looked at access, architecture, service management. In their second pass, they really looked at the relationships at these different organizations, because that makes a difference in what you can do or what's possible. Data governance, the workforce that supports informatics resources or these enterprise data warehouses for research. And then phase 3 is looking at impact, demand management, sustainability, and accessibility. And this accessibility part was recommended by CTSA leadership. And I'm going to skip through that. So from that research at the consortium level, Boyd and the VPR and our enterprise IT leaders, as well as the research deans, put together this P3, this public partnership proposal that really is what led to the Iowa Health Data Resource. And these gaps were identified, and this proposal was designed to address these gaps, but access to data and data literacy was identified as one of those gaps that this proposal would address. Access to data sets, curated data sets around specific domains was another gap that was identified. And then access or the ability to put HIPAA data or patient data in a computational environment. So having a place where we can use existing computational services in an environment that matches with healthcare's expectation for data management. So that was submitted and awarded in 2021. Right now, we're about halfway through that project. So there's some background. And that's really what led to Iowa Health Data Resource. I'm going to pause right now. Are there any questions so far? All right. So we have 3 goals to address those gaps. The first goal is to improve the understanding and availability of health data on campus, really raising that literacy level and that data knowledge level. That second goal is building transformative data sets for health science research. And those are those domain-specific data resources that aren't simply just data, but data and expertise. And then the third, establishing that what we call a data enclave to process data with our existing computational resources. So that people goal, the first part of that people goal was to establish the intercollegiate advisory and implementation team. The people on those teams were identified by their research dean. And then we also identified staff on our own team to participate in this. This is really the liaison and literacy level. So the concept is we were bringing a brand new group of people from the health science colleges identified by the research dean onto our team, and then having them be a data liaison, elevating the level of scientific and research understanding, and then also learning more about the data resources that are available. The second goal is to build those transformative data sets. And that's really 3 pieces. Improving our core data set in that very left hand of that column of the diagram that I showed earlier. And then building those specific data marts, so those transformative data sets, using lessons learned from a couple of different programs that we've done over the last 10 years. And then expanding our use of our consortium or our research network data. We have a variety of different research networks that we also want to make sure that our community understands are available to them and that they can use for research purposes. And then third, technology. So in addition to establishing this data enclave and having a computational environment that we can use this data in that aligns with healthcare practices and policies, we also want to expand additional tools within the IHDR for our community to use, but also for our data liaison team to use. So coming back to the diagram I showed earlier, there's this concept of data sources, aggregated data structures, these consortium or institutional networks, transformative data sets or domain-specific data marts, informatics and domain expertise. So that's really that IAI team, and a security data enclave. And then we have access and query tools for our researchers to use with existing compute resources. So that's kind of a simplified version. We'll come back to this diagram a little bit later. So that first goal, improving the understanding and availability of health data on campus. We have this intercollegiate advisory and implementation team. When we started, we were awarded this award in July 2021. Our first part of that cohort dropped in. So we started, we had this concept of everybody participating on our team for 2 months. So an experiential learning process where we bring in faculty and staff from the health science colleges. They sit with our team and they participate in our data engineering or our query building. So they sit with our analysts and our consultants, and then they also sit with our data architects to understand the environment, understand processes, ask questions, and help us build resources. The very first thing that we did is we had a series of science of team science meetings to get this community that was identified together and really brainstorm around, these gaps have been identified. What are the things that we need to do? And this liaison team and these core competencies came out of that. So everyone kind of has these basic things that they do as a resource and as a liaison, to act as a liaison, to provide their domain expertise, to be able to demonstrate our self-service tools, and most importantly, continuous feedback. There are things that we don't see because we're in the weeds, but our faculty and our staff that are working and researching can see our gaps, and that's been very powerful. Our faculty, many of them lead one of those transformative data sets, so they're the scientific lead. They communicate out, much like I'm doing right now. Our faculty and staff on this IAI team are empowered to go back to their communities and communicate in the same way that I'm communicating. For staff, we have a formal data request process, which if I have time, I'll touch on, but where faculty come in, researchers come in, and they ask for a data set. And we have a data menu, and we work with them to put together a consult to identify, what's the research question, what's the cohort that will solve the question, and what are the data details that they need. And for our staff members, we want those liaisons from the colleges handling that for their faculty, because they have this expertise that my team doesn't necessarily have, and we can teach them the data and the processes to really facilitate that for their colleges. So we identified these core competencies. We started this experiential learning in different cohorts. And this is what this looked like at first. We had that science of team science meeting, and we had an orientation, and then we dropped our faculty and staff into these regular, what we call triage meetings, and then data request meetings, where we really scope out what they're asking for and figure out the right resources to match with that investigator. After 4 weeks, we then have them show up to our consult meetings and provide their expertise. So then they are working as part of our team, attending ad hoc consults, and then 2 times during this process, and I think it's actually on the next step. I'll skip there. So then translating, creating data sets, collaborating. So that was that experiential timeline. As true to continuous feedback, they told us right away, this was too much and they needed more context. So then we put together very quickly a set of formal learnings that included deep dives in domain-specific knowledge about data governance, about, if they hadn't done IRB training, about IRB, an overview of that enterprise data warehouse for research, really detailed as far as what's included in that. And then other specific learnings. Twice during this process, we sit down and we talk for 60 minutes to 90 minutes to get formal feedback, and help us identify what are things that we could do very quickly that would make a difference. What should we'd be looking at in 6 months, 12 months, 9 months, in a timeline to improve our processes. And then what are the things that we're not seeing or we're not thinking about, but the research community is thinking about? And that feedback has been really helpful in developing this process as we've started our second cohort. We have a new group going through and really improving this. So that's what that learning timeline looked like. These are the liaisons that have gone through our process so far. So in the first year, we added 17 new people to our team as liaisons that now act as the Iowa Health Data Resource and Intercollegiate Advisory and Implementation team members, but then they're also part of the BMI team. And so we've done this again. We're in the middle of fiscal year 23 or year 2, and we have 13 people so far, and we have a few more identified for our spring cohort. So that's our first major outcome, is building this community of liaisons and resources to really help us expand our knowledge, because we know data, but we don't always know the details of the science or the clinical details that we need to know. A second outcome is really creating information resource material. So this was other information that was identified through those brainstorming meetings. And as people went through the experiential learning, they put together a list, and part of the feedback, we capture that, we categorize it. We also share it with our evaluation team to identify gaps. And then really once we see a trend, we can start to address it. Some things are very easy, some things take time to do, but we've developed communication materials, boilerplates for grants, checklists, information notebook for our liaisons, and then data dictionaries that are available for all of our liaisons to use. And we're still in the process of developing more materials. So that's a second outcome. We also have some organization. So 2 of our faculty members are now co-leading with Boyd and I a faculty meeting where their primary focus is scholarship and grants. They also mentor new learners and new faculty. And then when needed, our staff IAI team members can ask them for consult time around specific research domains. And that's an advantage that we hadn't previously had. Our IAI staff members from the colleges, they meet every other week with my data team. They attend all the data triage meetings, and we get to consult with them when their expert support is needed. So here are some metrics. So I'm kind of a data geek. So it's really, I like to see what outcomes are. And this is one thing that I'm really proud of. I'm really proud of the team for doing. So prior to the IAI team, we rate our queries or our requests that come in by complexity. Tier 4 requests are custom, meaning we don't have any automation around how we get that data out. It's really done in a concierge manner, and we problem solve as we go. And we have ones in particular that are considered highly complex or extremely complex because of the number of resource hours that takes. And you can see the left-hand side of this line is from the time somebody says, I need something and I'm not sure exactly what it is. This dot is when we have a query that's agreed upon where the research team says, yes, this is the computable phenotype, or this is the cohort, and these are all the data types that I need for this cohort. And then the right-hand side of that line is when that data gets delivered to them. And you can see these are quite expansive in some cases. So post IHDR IAI team, we see that this is a much tighter, a much tighter time frame, meaning we are able to, with these experts that are now working with us, to much more quickly identify what the cohort is, what the data details are that are needed for the scientific question that our faculty and our research teams are asking. So this is one thing in particular our team is very proud of. And kind of another way to view this too is we see the number of requests that have come in. And this is time to delivery. The pandemic changed everything. A lot of people, you can see, we had a large jump in data-only research because people couldn't do traditional research recruiting, bringing people into a lab to ask them questions or have them do testing. So we saw this big jump, and we haven't really seen a dip. But as we implemented the IAI team here, we can see that time to delivery has reduced greatly with the IAI team's impact. And we can also see the number of those tier 4 custom requests has actually gone up in that same time. So not only have we reduced time to data set or product to research, we're able we've increased our capacity for that. So I'm going to stop right there. Are there questions about the IAI or the Intercollegiate Advisory and Implementation team before I move on to what our second goal was? And I think I can see something in chat here. All right, questions. Okay, all right. Okay, all right. So I'm going to move on here. Okay, so transformative data sets. This was our next goal. And when somebody comes in and asks for data, the request may be very simple or it may be highly complex. And we base that based on the number of hours we estimate it will take one of our data analysts and one of our data architects to put that data set or that data resource together. And what we found is that over time, this has changed quite a bit. Things have gotten more complex. People are working with more data. So our first goal in IHDR under these transformative data sets is before we build new data resources, is make sure that core set of data is better. So continuous improvement around that. One of the ways that we're doing that is having these scientists with domain expertise to come in and tell us where there are gaps or where things don't match. And we've had a number of faculty come in, whether it's our self-service tool or data models that we're working on, to really let us know when there's missing data or when there's data that is just not granular enough for them to be able to do their research. And that's invaluable. Understanding the data also helps us improve the core data set because we have more people that are able to speak to the differences. A question that we used to get all the time is, people are used to prospective data sets where there's a form, there are 20 questions, it's complete, it's completed over a period of time. So it's very nice, neat and tidy. We'll have researchers come in and, they'll ask for data out of the medical record and it will be spotty because I may have 2,000 blood pressure measurements in my medical record. Someone that's only been seen in outpatient for an annual visit may only have 10 blood pressure measurements. So there's not always the same level of data, and data isn't captured the same way across the house. Each clinic may have different forms where they collect data in, and sometimes we have to figure out, can we mash that together? Can we standardize that data, or are they unique data sets? And how do we satisfy what a researcher is looking for with that? So increasing that level of understanding about how the EMR works and how it's used in practice is really, really helpful for our researchers and our liaisons to note. Improving the documentation is also key, because sometimes it's a little bit of magic behind the scenes, what that means or how data comes in. And then our data leads really just providing that continuous feedback. We have our research network partners also provide that continuous feedback. So in the background, we are always looking to make sure that we are staying on top of our mapping, the EMR changes, other data source changes, and making sure those changes make their way into our data sets. So improving the core data sets, really part of that. And then these transformative data sets. So as requests become more complex and as requests become bigger, instead of a cohort of 30 or 50 or 300, we have researchers that are looking for cohorts of 50,000. And that changes quite a bit how, the amount of data, but also how they're using the data. And We started a project almost a decade ago with the Santillians in OB-GYN. And at the time, it was a mom-baby data mart. And now we're on our third instantiation, because sometimes data that we get out of the medical record isn't readily usable. We have to do things computationally to make it ready for them to use, or we standardize, normalize it. If we're bringing things in from 2 or 3 or 4 different data sets, our researchers don't want to see 2 or 3 or 4 different first names, last names, and birthdays that sometimes match perfectly and sometimes don't match perfectly. We take care of some of that, but we also do some prep work for them. And an example for their database, and if you're looking for another person to come and talk, Dr. Donna Santillian does a great presentation on the intergenerational knowledge base. So I'll throw that out right now. But when we think about moms and babies in the medical record, they are not in there. The medical record is really about the care a person receives and how we charge for that care. And when we think about that, we're really thinking about an individual. We're not thinking about a family or how the health of a mom could impact, the child at age 10 or at age 15 or the grandchild. So for the research that they're doing, we needed to figure out a way to connect that information and then deliver important information about intergenerational health. And then, but how does that look for sibling health? How does that look for mom-baby health? How does that look for dad-baby health? So we really spent quite a bit of time figuring out how to do that, how to add some computation. So if you have this set of diagnosis out of these, 300 diagnoses, and you have these lab tests, and this has happened, we can create a new field or a new data field that says yes or no, or true or false, to make it much easier for our research faculty to quickly do feasibility, to say, do we have a cohort that matches what we're looking for, and answer some really quick questions. So in an example we recently looked at with the Santillians is, they estimated asking a question, in a previous environment might have taken weeks and weeks and weeks to figure out the feasibility, have the data, and be able to do a quick analysis. They were able to do that in just a matter of an hour or 2. So that really makes a difference in responding to calls for proposal, but also getting those initial abstracts and papers out the door. So for the transformative data sets, we're taking that methodology that we used for that mom-baby data mart, which is now the intergenerational knowledge base, and also a project called UI BioShare, where we brought several different biobanks, individual biobanks across healthcare together in a single data resource, still preserving their autonomy to operate, but being able to cross-link that data. So instead of having to go to 30 different banks to say, do you have a person with a specimen that meets this criteria? They're between 25 and 35. They've had this diagnosis, they've taken this medication, and they have a saliva sample available. We put that together. So instead of going to 30 different places, we could do a search across that and then determine if that sample was available for research or if it was already reserved for a research study. So we took learnings from those 2 projects, and we're trying to jumpstart these, because we don't want to spend 10 years on developing a data resource that's specific and valuable to a domain. We want to spend a year and working with that group. And the principles around that is this sort of resource is collaborative. We can't do that without scientists. The mom baby or the intergenerational knowledge base took our informatics team, but it also took people from nursing, people from OB-GYN, people from pediatrics, people from neonatology, and people from epidemiology, as well as our clinical informatics staff to help us develop that resource. We use project management principles to do all of this. It's a formal practice where we do a lot of planning before we do any execution, so that we all are in agreement. And in that, we also use community-based decision-making practices. Takes a little bit longer to do that, but everyone works towards the same goal. And then our really at the center of this is understanding, the scientific goals, not just of an individual research question, but of a program of research, a lab or a department, and then understanding the scope of possible questions so that we can work that into the resource that we're developing. These are the transformative data sets that are in process for the Iowa Health Data Resource. We actually are adding new projects as we go. If you have any interest in this or any interest in seeing and hearing about these resources, I would encourage you to contact the faculty lead of that directly. And again, Dr. Santillan has a great talk about the intergenerational knowledge base. The last is research networks. So we participate in a number of research networks or consortiums of research that allow our researchers to expand their research beyond the borders of University of Iowa Healthcare and the state of Iowa. And these are great resources to take advantage. PCORNet is led here by Dr. Betsy Krushillis. And we have a number of studies that use the PCORNet Research Network. Trinetics, which we use Trinetics in a couple of different concepts. It's our self-service tool, but we also participate in a research network with about 60 other academic health centers. We are also part of the National COVID Cohort Collaborative, which is a data set centered around COVID research and comorbidities or multimorbidities around COVID. And then EPIC, our electronic health record, has a new tool called Cosmos, which is also centered around networks, and that's coming soon. And again, one of our goals within transformative data sets is really to make sure that the community understands that these resources are available for them to use if they're looking to expand their research questions beyond Iowa's data. Just a couple of quick graphics. So for PCORNet, this is a representation of the patient distribution that exists in the PCORNet data set. In our IAI team, we have a liaison. His name is Brian Grislak, and he can help our researchers get started using this tool. And this is an example of some of the PCORNet supported projects here. Our Trinetics Research Network, we participate in this, and this is nice because in the self-service tool, an investigator can look at a cohort at Iowa and then can go out and look at the research network and look at the same computable phenotype or cohort identity and see differences in what Iowa's population looks like, and then what the population across the participating networks looks like. And last, our NC3, the National COVID Collaborative, that data is in an enclave. It's in OMOP. There's a little bit of a learning curve in using that, but again, it's a great resource. There are 76 different sites contributing to the data, and not quite 20 million people. But it's a really great place to get started if a researcher is looking specifically to do research on COVID patients or COVID data. Oops. And I'm struggling here. There we go. So I want to stop right there. Any questions about kind of the transformative data set goal of our project? Okay, I'll talk a little bit about Data Enclave. So the kind of the first goal of this was to establish a data enclave. So one of the things to understand, and obviously you all do data management, is that our patient data is managed or is kind of the responsible party is University of Iowa Healthcare. So there are some practices around where that data can live in University of Iowa. And one of the requirements for this enclave was that data had to stay in a space that is managed by a UI healthcare employee. So what we needed to do was to design a solution that met the needs of our researchers, met the expectations of, oh, you've got to be kidding me. I've got an update that's starting, even though it's not due till the 26th. Anyhow, we'll see if this reboots my PowerPoint. Okay, so to meet the expectations of UI healthcare, to meet the expectations of our researchers, and then also work to take advantage of the existing computational resources that our university, our Iowa Research Information Technology Group provides. Argonne Computing Cluster, the High Performance Computing Cluster, and the Interactive Data Analytics Service. So that's really what we were looking to do. So what we did is we designed a solution that met all of the requirements from our stakeholders and from our leadership. So we deployed this. There is a direct network that runs to our secure storage. So this storage exists in healthcare, but once you're logged into either Argonne or IDaaS, you're able to connect to that secure storage. So our team deposits that data, and then a researcher can go about using that exactly as they would use those tools for any other data set. It went live earlier this year. We have a number of researchers that are already using this, and there are early adopters. And you can see we measure this in terms of how many terabytes they're working with and which of the two tools they're working with. So as I mentioned, the Enclave went live July of 2022. So it took us about a year to do. And then I asked for and got an approved training data set available. So it's a data set that researchers can use to test their algorithms on, or their learning models on. They can't do research on it, but what they can do is they can test on that before they put in their IRB. See if what they're thinking works. If their algorithms work, they can kind of get that pre-approved, go out, ask for IRB, get the data set that they're actually going to work with, and then they've already trained their models. So when they get that data, they can hit the ground running. We are also working on a couple of other tools internally for our team. One is a tool called Immerse, which is a search engine that sits on top of notes data. So our informatics team and our IAI liaison team can use that when they are doing consults and when they're putting together queries. A lot of data sits in notes and is not anywhere discretely. And that's one of the gaps that we've had and we've identified in the past. So what this will allow people to do is use that rich data that isn't typically available for searching in order to define cohorts, verify feasibility, and then search for an appropriate cohort list to ask for data extraction. And that we're working on that, and that'll be available internally to my team to help with researchers. We're also working on a new data model, and it's called OMOP, Observational Medical Outcomes Partnership. Many different informatics groups use this, but what we're really interested in, aside from interoperability, we're also interested in it because there are some very interesting self-service and query tools that can sit on top of that data model. And then one of the other things that we're doing with our IAI liaison team is exploring EPIC tools for research. How can we take advantage of all the tools that are available to us to help match researchers with the data sets that they're looking for? All right. So I'm coming back to this diagram again, and we have data sources. We transform, we aggregate, we normalize. We also push that to those interinstitutional networks, which are often grounded in a data model. So in a specific data model, taxonomy, ontology. We push that data into those transformative data sets that we were talking about. And then we have that our expert informatics team, but also those liaisons. This is the secure enclave we talked about, the access and query tools, and then our research community and the compute nodes. What that looks like in a little bit more detail is this enterprise data warehouse for research architecture, where we bring a number of source systems in, we transform, we normalize, we match to data models, we match to taxonomies, and these are those data sets. These are those experts where it used to be us, but now we have experts across the health science group. We have that enclave where we can push data from our normalized layer here, our transformative data set, into that enclave for researchers to use. And the researchers can come in and use our self-service tools, our data request tools to access that data. So that's what that environment looks like in a little bit more detail. So far, this is just a sample of IHDR supported grants. This is one of the things our faculty are working on, making sure that we're writing grants. We're utilizing these resources. We're mentoring students and letting them use these resources as well, asking them to use these resources. So we're very excited about this going forward. And how can you help our faculty leverage this? So, the things that we're suggesting people do is get training in some of our self-service tools, ask us for a consult, or have us come to a consult with a researcher that you're already working with. Reach out to our data liaisons. So if you are the liaison to one of the health science colleges, partner with that liaison, that faculty member, that staff member that's a liaison. Engage the faculty that are leading transformative data sets, that they're leading it from either their research domain or collaboration with a number of other investigators. Make use of the data enclave. It's the first time that we've had the ability to put data that has PHI out of UI Healthcare and make it available, put it into a secure enclave and make it available to our computational tools. So we just can't over communicate that. Tap into those inter-institutional networks. That is a rich resource that we would encourage our researchers to use. It's definitely a very interesting option if you're looking to expand research, or start with a pilot with Iowa data and then expand later for a full grant. Invite us to come and talk to another group. If you're already working with a research lab or a department, you think some of this material fits, have us come out and co-present with you. Tell somebody that wasn't here about this, and they can connect up with us. And then if you're really interested in this, contact me or Ash Hoberg, who helps me lead the IAI team. We are looking for people to join the spring cohort and the cohort that's starting in July. All right, so I'm going to pause here for questions, and then we can talk more about some of the details if people are interested about the ins and outs of actually getting data or the data request process. So I'll stop right there, and we can answer questions. Otherwise, I have more details or more materials if you're interested.